I say good evening to everyone because it is now 5:45, uh, and I am thankful to scientific committee for giving me this opportunity. My talk is very simple and it's on pulse to achieve perfect capsulorhexis in difficult cases. Obtaining a perfect capsulorhexis is a vital component of any cataract surgery. A well-centered capsulorhexis with 360-degree overlapping capsular edge prevents IOL tilt and optic decentration. In complex cases, the capsulorhexis is even more critical, and sometimes it can determine either the success or failure of your case. Cases where perfect rhexis is challenging, like white and hypermature cataract, intumescent cataracts, Morganian cataracts, subluxate lenses, traumatic cataract, pediatric and posterior polar cataract. Uh, while we are doing capsulorhexis in a mature cataract, so always stain the anterior capsule with the trypan blue. It enhances the visibility of the anterior capsule, and always use high molecular weight viscoelastic to keep the AC formed throughout the procedure. Now in the first video, it is very old video where I used to do capsulorhexis through the main incision, and but the problem is that after this capsulorhexis is going in the periphery. So what to do now? So I again injected the viscoelastic, and then with the Utretra forceps I completed the rhexis because it is more controlled than the cystitome, and the direction of tear should always be towards the center. Then this video is 3-year-old video where I used to perform the rhexis through the side port. Because the chamber stability is more, chances of leakage of viscoelastic is also less. So always keep your forceps upwards towards the cornea. Chances of leakage of viscoelastic will be very less. And with the microrhexis forceps, we can do the rhexis. Now again there is a problem. So actually bad habits are very difficult to die. So I again introduce my microrhexis forceps through the main incision, and because I was more confident with the main section. And anyhow, I completed the rhexis, and it's a beautiful rhexis. See. Again, two-stage capsulorhexis is a beautiful technique. So what you have to do to make initial puncture, and then after making the initial puncture with the forceps, you make very small rhexis, that is 2 to 3 millimeter in shape, size. After making this, you have to remove all the liquefied cortex with the help of Simcoe cannula, and you can do the milking of the anterior capsule as well. Today Dr. Harbanslal shown one video there, and he said that even without puncturing the capsule you could reduce the pressure. So that is also very good technique. Then after making the small rhexis, you cut it with the Vanna scissor, and then with the help of capsulorhexis forceps we can make the rhexis, because intralenticular pressure has gone down. So it's like making a rhexis in the normal cataract. You don't need any fancy needles or other rhexis type of rhexis. Then one more type is the spiral rhexis, and in this case what we have to do, we first raise the initial flap, and then you have to go into the spiral manner. You go on increasing the rhexis, and that is also the good way of doing rhexis in the mature cataract, and you can complete the rhexis, very nice 5.5 millimeter rhexis without any problem. This rhexis I have learned from Dr. Mohan Rajan. He used to do it, and it is known as puncture rhexis. So in this rhexis, what we make the initial puncture with the help of the phaco needle and keep the bevel needle down, just make one puncture, and there is a central puncture. After making this, the pressure is reduced. The phaco power should be 40, vacuum should be 300 to 350, and you should use the burst mode. But the problem I have faced is, one, the capsule is very fragile, and second, when you make the puncture with the phaco needle, the margins are very ragged. It is not regular like needle, so it is difficult. And sometimes, like in this case, another case, when you give the first burst, there may be chances of zonular dialysis because you don't know about the force applied to the nucleus. Then what is the main principle to, to prevent the Argentinian flex sign? Because intralentricular pressure is high, so there is a tendency of capsulorhexis to run away, and if you make first initial puncture, it hardly takes 10 to 11 seconds and there is a Argentinian flex sign. You are helpless. See in this video like this. So how to overcome this? Make a small central capsulorhexis in C shape. The vector forces act in the same direction, so they resist the radial extension of the rhexis. In a straight cut, like in this video, the vector forces acts in the opposite direction, so chances of radial extension is very high. And I used to give IV mannitol pre-operatively to reduce the vitreous pressure, so chances of extension is less. This is capsulorhexis in the intumescent cataract, where it's rather a Morganian cataract. You just give the puncture and see the whole fluid has obscured your vision, and so remove this with the help of the needle. Use good viscoelastic, and after making the first initial incision, you can do the rhexis very well, even with the cystitome, like in this case. This is also the video of the two-stage rhexis. Same, but here I perform the rhexis with the help of the microrhexis forceps from the side port. So it is more controlled rhexis. Now in the Morganian cataract, the cortex gets degenerated and liquefies the moment you puncture it, and the nucleus floats. So there is no support to your capsule from behind. See in this case, everything comes out. Then with the help of the you remove it and again take the microrhexis. For see the nucleus is going here. So there is no support, and even you can put little bit viscoelastic in the back. So rhexis will be easy. And you should be very careful because capsule is fragile, thin and slippery, and zonules may be compromised. So one should be careful, otherwise there may be zonular dialysis and you will be in trouble. This is a case of traumatic cataract where there is a subluxation here, and I always start the rhexis away from the subluxation. It is difficult to lift the initial flash because of the lax capsule, and one point to be remembered in this case is you have to take the central point of the lens, your decentered lens, rather than the center point of the pupil. Otherwise, there may be chances of decentration of the lens or the like this. This is the capsulorhexis in the pediatric cases. As the anterior capsule is very elastic, the zonules are very tight, and there is a vitreous upthrust, so chances of extensions are very high. Staining of the capsule not only reduces the it reduces the elasticity and helps in achieving the perfect capsulorhexis. So even with the, and then again I took the microrhexis forceps from the side port, and we can complete the rhexis in a. Now nothing I am to say in the capsulorhexis in the posterior polar cataract. So do not overfill the anterior chamber with the viscoelastic because there may be pre-existing PCR. And rhexis should be of an adequate size. In a small rhexis, nucleus handling is little bit difficult, and if there is a PCR during the phaco, the chances are very high. So if the rhexis is of adequate size and small, we can put the lens into the sulcus. So this is all. To summarize, capsulorhexis requires a balance between the centrifugal forces applied to the anterior capsule by the surgeon against the centrifugal forces from the zonules, which tends to diverge the tear towards the periphery and the force of the lens material as well. With meticulous attention to the technique and balancing all hydrostatic and mechanical forces on the capsular bag, capsulorhexis can be achieved in a complex cases. Thank you very much.
Thank you, sir. In addition to this, if there's an intermittent cataract young patient, you can always see and appreciate the vacuoles, and ION master nowadays can also show you entire lens thickness where you can appreciate the same vacuoles. We also do consider doing yak cap preoperatively, as well as if the age is more and the vacuoles are less, then what Dr. Husband showed as lens massage, we do that preoperatively. Yeah. So if the age is young, vacuoles are more, and you see that on OCT picture of the iron master, we do a pre-op yak cap as well.
Very nice presentation and video, sir. A couple of things I want to say for beginners is, if you're going to do a rhexis from the main incision to a rhexis forceps, so always loosen your speculum. Speculum is one factor which presses on the globe when a vitreous upthrust occurs. One is that, and secondly, you should never stop in the subincisional area. The moment you stop in that area, the flap comes out, and then you are in trouble. So either stop short of it on left side or on right side. So these are 2 points. And thirdly, if you are expecting a complication like a posterior polar cataract, you can either make oval rhexis or make a slightly smaller rhexis, because you might want to capture the IOL if you are going to put a 3-piece IOL. So these are few of the points we teach our fellows. Another thing is, you can also do a phaco in a small rhexis, put in the IOL, and then enlarge the rhexis, so it's always safer. If at that point, even if it extends, you're still safe, the IOL is already inside. So, nice presentation.
Thank you, sir.
Oval rhexis is very useful, I think, in the posterior polar cataract, because it is very easy to remove the sub-incisional cortex also, and doing the vitrectomy from all the area, and we can easily put the lens in the oval rhexis. Even capture of the lens is also easy. So very nice presentation.
Thank you, sir.
Thank you, Dr. Gupta.